Okay, so hi everyone. Today's topic is going to be on a little rare cause of headache, that is SUNCT and SUNA. So I've uploaded my class on cluster headache. And the notes for all the videos that I've taken till now on Neuraxis Pro. I've put the link in the description so you can access my content over there. Okay, so let's go into the class. So SUNCT and SUNA come under a group of disorders known as trigeminal autonomic cephalalgias. So the other headaches that come under this group are going to be cluster headache, and paroxysmal hemicrania, paroxysmal hemicrania, and hemicrania continua. Hemicrania continua. Okay, so these are the disorders that come under trigeminal autonomic cephalalgias. The most common trigeminal autonomic cephalalgia is going to be cluster headache. Okay, so what are the full forms of SUNCT and SUNA? So SUNCT stands for short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. So the patient is going to have conjunctival injection and tearing, it's SUNCT. If the patient is not going to have conjunctival injection or tearing, or only going to have one of these two, it's going to be SUNA, which stands for short-lasting unilateral neuralgiform headache attacks with cranial autonomic symptoms. All right. Now come to the clinical features. So just like in cluster headache, it's going to be a strictly unilateral headache, usually periorbital and temporal in distribution, and it's going to be a severe stabbing, burning, or throbbing pain. But the attacks are going to be very short-lived. Okay, it's going to last for only 5 to 240 seconds, but the patient can have multiple attacks per day. So around even 3 to 200 attacks per day can occur. Okay. So there are three patterns of headache that can occur in SUNCT and SUNA. So one, the patient can have single stabs of headache. Okay, usually these attacks last for 58 seconds. And then we have a group of stabs. So we have a group of stabs, no headache, again a group of stabs. So this pattern usually lasts for around 396 seconds. And then we have the sawtooth pattern. Okay, so this is an important MCQ. Which headache disorder do we get? Sawtooth pattern. So in sawtooth pattern, the patient is going to have a group of stabs. Okay, but between the headache, the patient is not going to have a complete relief of pain. So a group of stabs of attack, then a mild headache, and then another group of stabs of attack. So this usually lasts for around 1160 seconds, and this pattern is known as sawtooth pattern. Another very classical feature of SUNCT and SUNA is the presence of cutaneous triggers. So if in case you're going to touch the patient's face, the patient is going to have certain cutaneous triggers of the face which will trigger the attacks of SUNCT and SUNA. So what is the other condition, neurological condition that has cutaneous triggers? That is going to be trigeminal neuralgia. So how are we going to differentiate? Trigeminal neuralgia from SUNCT and SUNA? So number one, refractory period. Refractory period is going to be present in trigeminal neuralgia, whereas there is no refractory period in SUNCT and SUNA. And next, in trigeminal neuralgia, there are going to be no autonomic symptoms. There are no autonomic symptoms like conjunctival tearing, nose block. Those symptoms are not present in trigeminal neuralgia, but however, they are present in SUNCT and SUNA. Okay. The other feature of SUNCT and SUNA is there is no response to indomethacin. So remember the trigeminal autonomic cephalalgias that responds to indomethacin, that is the indomethacin effect, is seen in paroxysmal hemicrania and hemicrania continua. However, in SUNCT and SUNA, there's not going to be any response to indomethacin. This point is a very, very important MCQ question. Okay, so this is about the features, the clinical features. So what investigation should you do? It's vital that you do neuroimaging in patients with SUNCT and SUNA because you have to rule out secondary causes of SUNCT and SUNA. The two important secondary causes are going to be posterior fossa lesions and pituitary lesions, especially pituitary lesions, don't forget. All right. Now coming to the treatment. So how are you going to, mainly treatment is going to be prophylaxis because the headache is such, it's very short lasting. There's no point of treating an acute attack. So preventing the headache is more important than treating the acute attack. But however, if they're asking a question, what is the drug of choice for an acute attack? The answer is lignocaine, IV lignocaine. And what is the drug of choice for prophylaxis of SUNCT and SUNA? It's going to be lamotrigine. Okay, so many people confuse this. Okay, so if you take cluster headache, you're going to take cluster headache, the drug of choice for prophylaxis over here is going to be a calcium channel blocker, that is verapamil. But if you're going to take SUNCT and SUNA, the drug of choice is going to be lamotrigine. It's going to be lamotrigine. So don't forget this. These two are commonly confused. Okay, so the dose is around 200 to 400 milligrams per day. The other drugs that can be used are topiramate, gabapentin, carbamazepine, and in refractory cases, you can try greater occipital nerve injection or occipital nerve stimulation. So I think I covered most of the important points. Thank you.